Chapter 9, Video 2. In this video, we're going to begin with talking about premature junctional complexes. Premature junctional complexes are also known as PJCs. This is simply a premature beat that originates in the AV junction before the next sinus beat is due, okay? So the sinus node is the pacemaker of the heart. It fires, it sends the signals down the electrical pathway through the AV junction, through the ventricles. What happens is, before the next SA node or the next sinus beat is due, the AV junction sends out a signal. It's caused by irritable tissue in the AV junction that fires, and it takes over the sinus node. So looking at our criteria, this can happen at any rate. It's regular, but it's interrupted by a premature beat. And the P wave is inverted. It can precede or it can follow the QRS, or it can be absent, which means it's hidden inside of the QRS. And this is going to depend on where it actually came from in that AV node that we talked about in the previous video. But it can be inverted, it can precede, or it can follow the QRS, or it can be absent, which means that it's hidden inside. With the premature junctional complex, the PR interval is less than 0.12 seconds if the P wave precedes the QRS, okay? So if we have the P wave that is in front of that QRS, then that PR interval is going to be less than 0.12 seconds. The QRS is less than 0.12 seconds, and the causes here are stimulants, hypoxia, heart disease, nicotine. There's usually no ill adverse effects, and we treat the cause. So when we're looking at this, what is the first question that we're going to ask ourselves? So the first thing that we're going to ask is, what about the QRS complexes? Are there QRS complexes? So take out your pencil and piece of paper and let's write all of this down. Yes, we have QRS complexes, and they all appear to be shaped the same. Now, let's figure out the regularity. So let's march this out. And if we march this out on our piece of paper, we're going to see that all of these march out the same, but when we get to here, we have an interruption, and we have an interruption here. So it's regular, but it's interrupted by two premature beats, okay? So QRST, P, QRST, P. Look, what's going on with the P? It's a little bit different here. It's pointed downward. QRST, that's a little bit deformed. QRST. Then our P goes back to normal, and then we have a change over here in the P. So the fourth beat and the eighth beat are premature beats, but they don't have P waves. We have a P wave here, but this one could possibly, it's a little bit inverted there, but then we don't see anything here, and we don't see anything here. So we don't have P waves, but on the PR intervals that we do have, it's a 0.16, and then our QRS is 0.10 in width. So we have a sinus rhythm. We have QRS, P, QRST, P, QRST, and then this one changes, and this one changes. So overall, we have a sinus rhythm, but we've had two premature junctional contractions. And the reason we know these are premature junctional contractions is because it's not a PAC. We don't have anything hidden over here in the T wave. We just don't see this P wave, and it rolls in faster, okay? Not seeing that P wave is going to tell us that it's hidden inside of the QRS, which means this is happening in the middle of the AV junction, which we'll get into that later. But this is a sinus rhythm with a premature junctional contraction. Now we're going to move on to junctional bradycardia. Junctional bradycardia is a rhythm with a heart rate slower than usual, okay? The higher pacemaker has failed. So with junctional bradycardia, the higher pacemaker, meaning the SA node, has failed. The AV junction is working here, and it's providing escape beats. So the SA node has failed, and the AV junction has gone to work, okay? So we're going to see a rate of less than 40, okay, with junctional bradycardia. Remember, with the AV junction, we said that it provides an inherent rate of 40 to 60. But in this situation, we're having junctional bradycardia. So that rate is going to be less than 40 because that AV node is firing slower. But normally the AV node serving as the backup pacemaker would provide a rhythm, a rate of 40 to 60. But in this situation, it's junctional bradycardia because it's slower. So we have a rate of less than 40. Our regularity here is regular. The P waves, again, can be inverted or they can be hidden inside of the QRS. They can be inverted before the QRS, or they can be inverted after the QRS, or they can be hidden inside of the QRS where we don't see them. If you do see them, the PR interval is less than 0.12 seconds if the P wave precedes the QRS. So if it's in front of the QRS, we should have a PR interval of less than 0.12 seconds. The QRS is less than 0.12 and the PR interval is less than 0.12. There's different causes of junctional bradycardia, and vagal stimulation is one. And just to make sure you're familiar with vagal stimulation can be triggered like when you're having the, if you're bearing down to have a bowel movement, that would stimulate that vagus nerve. We can have hypoxia. We can have sinus node ischemia, meaning that tissue around that SA node is dying, or we can have heart disease. The adverse effects include decreased cardiac output. If we have a slow heart rate, it can cause that decreased cardiac output. The treatment here is going to be atropine. Remember, it speeds up that heart rate. We may have to put in a pacemaker. They may need oxygen. If we are giving patients drugs that slow down the heart rate, then we may need to hold those. We may need to hold that bradycardia-inducing medication. We may have to consider giving epinephrine or dopamine infusion to increase the heart rate. But we want to prepare this patient. One of the big things that we need to do with these guys is make sure that we prepare them for immediate transcutaneous pacing. This is a process of attaching a pacemaker to the patient's skin. So we want to prepare these guys for that transcutaneous pacing. And again, we'll give atropine if the pacemaker is not immediately available. So looking over here, let's go through this. What is the first thing we're going to ask ourselves? Do we have QRS complexes? We do. Are they shaped the same? They're different. This is not our typical QRS complex, but we do have them, and they are shaped the same, and the rhythm is regular. And if you count the little blocks between the R and the R, we'll have a heart rate of 23. That's very slow. The P waves are absent, or they're not visible in this slide. The baseline looks a little jittery here, so we may have a little bit of somatic tremor there. But the PR interval here is not applicable. The QRS interval is 0.12. It is wider than normal. This is a little bit wider than normal. So we have junctional bradycardia with a wide QRS. And we know it's junctional bradycardia because we're following our criteria and we're looking at that heart rate. It fits the criteria of junctional bradycardia. That is all for this video. We will begin junctional rhythm in the next video.